This podcast is brought to you by Carvana. Carvana makes car selling fast and easy from start to finish. Enter your license plate or VIN and get a real offer in seconds, down to the penny. If you accept, Carvana will come pick up your car from your driveway. Or you can drop it off at one of our car vending machines. Either way, you get paid instantly. It's fast, transparent, and 100% online. Car selling that saves your time. That's Carvana.
Carvana.
Pickup fees may apply.
This is Dr. Ted O'Connell with the Med Prep to Go Step 2 podcast. Today we'll be reviewing 3 endocrine questions. Just a reminder that you can find these questions and many more over at medprep2go.com. If you'd like to get involved in helping us to develop questions for this free question bank, please feel free to email me directly at ted.medprep2go@gmail.com. If you like what we're doing, please subscribe and let your friends know about this and consider giving us a review as well, as all of that helps us a lot. All right, let's get started with the first question. A 33-year-old woman presents to the emergency department with rapid onset confusion, severe abdominal pain, and vomiting over the last hour. A collateral history from her partner reveals that she has been having unusual salt cravings and lightheadedness upon standing over the past 2 months, but had put this down to her recent increased stress from work. Past medical history is significant for Graves' disease, which is well controlled on carbimazole. Vital signs are temperature 38 degrees Celsius, which is 100.4 degrees Fahrenheit, blood pressure 80 over 59 millimeters of mercury, pulse 92 beats per minute, and respirations 18 per minute. On physical examination, the patient has a capillary refill time of 4 seconds and dry mucous membranes. A generalized bronze skin tan is also noted. Pertinent laboratory studies include the following: sodium 128 millimoles per liter, potassium 6.0 millimoles per liter, glucose 3.1 millimoles per liter. Intravenous access is obtained and the patient is transferred to the intensive care unit. Which of the following is the definitive therapy for this patient? A, intravenous 0.9% sodium chloride. B, intravenous 5% dextrose. C, intravenous hydrocortisone. D, intravenous insulin. Or E, intravenous norepinephrine. The correct answer is C, intravenous hydrocortisone. This patient is experiencing an acute adrenal crisis on a background of previously undiagnosed Addison disease. As it is a life-threatening medical emergency caused by severe glucocorticoid deficiency, the definitive therapy is rapid administration of glucocorticoids. Hydrocortisone has both mineralocorticoid and glucocorticoid activity, making it the preferred glucocorticoid for treating adrenal insufficiency. If hydrocortisone is unavailable, alternatives include prednisolone, prednisone, or dexamethasone. Answer choice A, intravenous 0.9% sodium chloride, is incorrect. Fluid resuscitation with intravenous sodium chloride 0.9% is also essential in the management of an acute adrenal crisis, as patients present hyponatremic and dehydrated, but it will not reverse the underlying cause of the hyponatremia. Hypotonic saline should not be used because it can worsen hyponatremia. Answer choice B, intravenous 5% dextrose, is incorrect. Intravenous 5% dextrose will help with the patient's hypoglycemia, but will not reverse the underlying cause of the hypoglycemia. Answer choice D, intravenous insulin, is incorrect. Hyperkalemia can be reversed with insulin, but this will not treat the underlying cause of the hyperkalemia and will actually make the hypoglycemia worse. Answer choice E, intravenous norepinephrine, is incorrect. Vasopressors such as norepinephrine are not a typical part of the management of acute adrenal crisis. The key learning point for this question: fluids and glucocorticoid replacement are the mainstays of treatment for an acute adrenal crisis. Glucocorticoid administration is the only definitive therapy for this condition, as it targets its underlying pathophysiology. Question 2. A 21-year-old woman presents to the emergency department via emergency medical services after being found somnolent and difficult to arouse in her dorm room by her roommate this morning. Past medical history is only notable for heavy menstrual periods. Current medications include only an ethinyl estradiol norgestimate oral contraceptive pill. Her father has hypertension and hyperlipidemia, and her mother has rheumatoid arthritis. The patient drinks 3 alcoholic beverages on the weekends and does not use tobacco products. The patient's roommate states she occasionally smokes marijuana and is not aware of any other substance use. The patient's roommate states for the last week, the patient has been unusually fatigued and her vision has been blurry. The patient attributed this to spending many hours on her computer writing her final paper for her senior project. Her roommate states she has also been drinking significantly more water and reported intermittent abdominal pain and general malaise. Vital signs are temperature 37.8 degrees Celsius, which is 100.0 degrees Fahrenheit, blood pressure 95/62 millimeters of mercury, pulse 110 beats per minute, and respirations 28 per minute. Physical examination reveals a somnolent woman who rouses to sternal rub and is unable to follow commands. Her pupils are 4 millimeters bilaterally and are reactive to light. Respirations are exaggerated and deep. There is a normal S1 and S2, and pulse is tachycardic but regular. Skin is erythematous and warm to touch diffusely. The patient has dry mucous membranes and increased skin turgor. Relevant laboratory findings include the following: pH 7.12, PaCO2 18 millimeters of mercury, PaO2 79 millimeters of mercury, potassium 3.0 milliequivalents per liter, and glucose 682 milligrams per deciliter. Which of the following treatments is the most appropriate next step in the management for this patient? A, 0.9% sodium chloride, B, 0.9% sodium chloride with potassium replacement, C, 0.9% sodium chloride with sodium bicarbonate, D, intravenous regular insulin bolus, E, SGLT2 inhibitor. The correct answer is B, 0.9% sodium chloride with potassium replacement. This patient is in diabetic ketoacidosis, DKA. Once the diagnosis of diabetic ketoacidosis is made, the patient should immediately receive intravenous rehydration. Insulin should also be quickly started. However, because insulin causes the influx of both glucose and potassium into cells, it is important to evaluate a patient's potassium level prior to initiation of insulin to avoid hypokalemia. This patient is already hypokalemic prior to receiving insulin, so she should receive potassium replacement with her IV fluids. Even patients who have normal potassium levels may eventually require potassium replacement after insulin is started, and so they should be periodically monitored for hypokalemia. Answer choice A, 0.9% sodium chloride, is incorrect. Intravenous fluid should be initiated for resuscitation of patients with DKA. However, with this patient's hypokalemia, it is important that this patient receives potassium replacement with those IV fluids. Answer choice C, 0.9% sodium chloride with sodium bicarbonate, is incorrect. Sodium bicarbonate is administered with fluids when patients with DKA are profoundly acidotic, that is, with a pH of less than 6.9. Answer choice D, intravenous regular insulin bolus, is incorrect. Starting insulin is an important treatment for DKA, but starting intravenous fluids is the most appropriate next step given the profound dehydration caused by DKA. Answer choice E, SGLT2 inhibitor, is incorrect. SGLT2 inhibitors do not have a role in the treatment of DKA. The key learning point: patients in DKA with hypokalemia, and even most of those with normal potassium levels, should receive potassium replacement prior to the initiation of insulin, as it will worsen hypokalemia.
From writer-director Ryan Johnson.
The Holy Grail, a perfectly impossible crime.
Wake Up Dead Man has critics singing its praises.
God help me. Anything else?
It's a deliciously entertaining mystery.
That's nice.
It's certified fresh.
It's a miracle.
Okay, you're freaking me out now.
It's the best Knives Out movie yet.
This case is solvable, right?
Oh, you'll see. It's fun.
Wake Up Dead Man, a Knives Out mystery starring Daniel Craig. Now playing on Netflix.
Question 3. A 36-year-old woman is brought to the emergency department by emergency medical services after being found on the ground in an alley with altered mentation. Initial vital signs are temperature 36.8 degrees Celsius, which is 98.4 degrees Fahrenheit, blood pressure 106/50 millimeters of mercury, heart rate 131 beats per minute, respirations 31 per minute, and oxygen saturation 95% on room air. She appears to be somnolent, and she responds minimally to name calling. She mumbles to the emergency department physician that she has been feeling nauseated and her belly hurts. The patient's medical history is unknown. Physical examination is grossly unremarkable. Her initial laboratory findings are the following: white blood cell count 12.0, hemoglobin 15 grams per deciliter, MCV 89, platelets 307,000, sodium 136 millimoles per liter, potassium 5.6 millimoles per liter, chloride 98 millimoles per liter, CO2 15 millimoles per liter, glucose 612 milligrams per deciliter, BUN 16 milligrams per deciliter, creatinine 1.3 milligrams per deciliter. Her urinalysis is positive for 3+ ketones, 3+ glucose, trace blood, and the specific gravity is greater than 1.030. An initial ABG shows pH 7.23, PCO2 30.9, PO2 55.8, bicarbonate 15.6 on room air. Her electrocardiogram shows sinus tachycardia without significant ST or T-wave changes. Chest X-ray shows no acute findings. CT scan of the abdomen and pelvis shows no acute processes. After a bolus of 1.5 liters of intravenous fluids and administering an intravenous insulin push, the patient's mentation improves. The patient reports she has a history of type 1 diabetes, but she has lost access to her insulin as she recently became homeless. Considering the most likely diagnosis, which of the following would be the most appropriate next step in management? A, continue to administer fluids. B, give bicarbonate to raise the patient's pH. C, give sodium polystyrene sulfonate to decrease the patient's potassium. D, order antibiotics as laboratory findings show leukocytosis. Or E, prepare for intubation as the patient's respiratory rate is high. The correct answer is A, continue to administer fluids. This patient's clinical presentation is concerning for diabetic ketoacidosis, DKA, which is characterized by the triad of hyperglycemia, ketonemia, and elevated anion gap metabolic acidosis. DKA symptoms include nausea, vomiting, abdominal pain, polyuria, polydipsia, weight loss, and if severe, neurologic symptoms such as lethargy, somnolence, and coma can occur as well. Physical examination findings typically include dry skin, and dry oral mucosa, which suggest a low volume status, and tachypnea, which acts as a compensatory mechanism for metabolic acidosis. Laboratory findings typically include marked hyperglycemia, hyperosmolality, and high anion gap metabolic acidosis. Urinalysis typically shows positive ketones and a high specific gravity suggesting volume concentration. Remember that sodium glucose cotransporter 2 inhibitors can induce euglycemic DKA, in which the blood glucose can be normal. Treatment for DKA should begin promptly with intravenous fluids, insulin, and monitoring potassium and the state of acidosis with frequent laboratory checks. Remember that fluid deficit is often underestimated during resuscitation. The goal is to replace the total volume loss within 24 to 48 hours while monitoring the patient's electrolytes and hemodynamic status closely. Answer choice B, give bicarbonate to raise the patient's pH, is incorrect. The patient's bicarbonate is 15.6 millimoles per liter, and ABG shows a pH of 7.23, which do not meet criteria for bicarbonate administration. Typically, bicarbonate is administered when the pH is less than 6.9, or sometimes less than 7.0, depending on different resources. And this is done to avoid cardiovascular complications. In general, for anion gap metabolic acidosis, the underlying cause should be addressed, such as the diabetic ketoacidosis in this case, instead of just administering bicarbonate. Answer choice C, give sodium polystyrene sulfonate to decrease the patient's potassium, is incorrect. In most cases, potassium elevation without ECG changes does not warrant treatment. DKA patients are typically deficient in potassium, even though laboratory findings reveal elevated potassium. This is due to volume depletion and insulin deficiency, as most of the potassium is concentrated extracellularly. Insulin administration will drive potassium into cells and lower the number fast. Electrolytes should be monitored very closely during the treatment course. Answer choice D, order antibiotics as laboratory findings show leukocytosis, is incorrect. Leukocytosis by itself does not indicate an acute infection. It can also be part of the stress response. This patient's physical examination, chest X-ray, and urinalysis are not suggestive of an acute infective process. Answer choice E, prepare for intubation as the patient's respiratory rate is high, is incorrect. Although this patient's respiratory rate is high, she is conversational and she does not appear to be using accessory muscles or showing signs of being tired out. There is no indication for intubation at this time. This patient is likely having Kussmaul breathing to compensate for the metabolic acidosis. Doing a Winters formula calculation to predict the PaCO2, which should result if there is appropriate respiratory compensation for metabolic acidosis, can be performed for confirmation. The key learning point for this question: patients with DKA have a significant volume deficit, which should be replaced promptly while monitoring their hemodynamic status and electrolyte status closely. Okay, so that's it for this episode, but please do check out our other episodes. Reminder that you can find this question and many more at medprep2go.com. And if you find the content of these questions useful, I suggest you also check out the USMLE Step 2 Secrets podcast.